Hello and welcome back to our EMG series. I've been having some fun lately with AI-generated images. Right there, Sherlock Holmes as a physician detecting anomalies on EMG tracing, and then here played around with some, well, kind of analog style EMG machines from days of yore, which I actually like a lot. I've had some students over the years ask me about how EMG came to be, so I'm actually going to do a history of EMG video pretty soon, which has some fun older EMG machines from the early days of testing. All right, let's get started. All right, and we start out in our usual style, beginning with sensory studies, withholding some of the clinicals so we can build our differential and work through this case. And we have some of the basics here: median, radial, ulnar, sensory, but we do have some slightly less common ones: medial and lateral antebrachial cutaneous sensory. Next slide, we have a thumb, median, and radial sensory latency difference study, and this is all pretty basic stuff here, all bread and butter for learners of EMG and interns and students and whatnot. But we can build a decent differential right off the bat here. So from the get-go, median, ulnar, and radial, these are all standard studies and might not help point things in a certain direction, but usually when we do EMG, we're only doing one or two of these. We don't usually do all three. If we are doing all three, that should kind of raise lights in your mind that, well, peripheral neuropathy might be on the differential here in terms of what we're looking for. That median sensory across the palm, if you go back in the slides, I do like doing that. You do one at the wrist at 14 centimeters, and then at 7 centimeters, you do one at the palm, and then you can get a conduction right across the carpal tunnel. So that might be a hint. And also, this is part of the combined sensory index testing, the median radial sensory latency difference to the thumb, the other being to the ring finger, and the last one being an orthodromic sensory across the palm, median and ulnar. So maybe we're starting to look for CTS. That's another thing we could build in this differential. But throwing the other ones, medial and lateral antebrachial cutaneous sensory, when do we do that? That should also trigger an idea of, yeah, plexopathy. So we already have three things that we could be looking for in this case. Let's talk a little bit about plexopathy. When we do our standard plexopathy screen, well, we're usually doing the thumb, median and radial, the long finger or middle finger, median, and then the pinky, the ulnar. And why do we do this? Well, if we have an upper trunk injury, those are the nerves that are going to get knocked out. So you make sure you hit your sensory median and radial to the thumb. You can also add lateral antebrachial cutaneous sensory to the mix since it comes off over here as part of an upper trunk injury. There we go. If we have an upper trunk injury right there. There are some other ones that you can think of too if you want to do, right, suprascapular, do the superinfraspinatus. You can do musculocutaneous as well. But these are kind of the standards. Now, for middle trunk, we do the median to the long finger, not the index finger. There are actually some studies out there that looked at this. There's a heck of a lot of variation for the index. It's just a very poor test for middle trunk. It's also sometimes used in carpal tunnel, but more and more people are switching to the long finger as a slightly more reliable test in terms of sensory. You've probably seen that if you do EMG and have been rotating around. Some people like the index. But the long finger is better because you can double one carpal tunnel study and two a plexopathy assessment. So that would be right here. And then moving on to the inferior or lower trunk, certainly ulnar to the small finger is going to get hit, and medial antebrachial cutaneous I often add on. I don't do lateral that often unless I'm really looking for something specific. If we spread that to motor studies and also needle EMG, we got biceps, FCR, and APB or ADM. Now, we don't often do nerve conduction to the biceps or FCR. I've done that occasionally, not very often, but this we do all the time. Now, let's move on to said motor studies. And whoa, what's going on here? Not our standard median and ulnar to APB and ADM. In fact, they're not even on this list. I went straight to axillary, long thoracic nerve, radial nerve, spinal accessory, and suprascapular. So what is going on here? Now we can build our differential a lot more. So if you want to pause it and think and build out three things that you can add to the differential, go ahead. And if you've finished pausing, here we go. Yeah, maybe it's an upper trunk plexopathy here. Maybe it's some strange shoulder pain case that's very difficult to figure out. Maybe there's some neuropathic symptoms, burning. The patient has some kind of aching and strange shoulder issue that they're trying to figure out. Or maybe it's a C5 radic, right? These are all things that we could be looking at when we're doing those studies. There is one that is not listed that you're probably waiting for, and well, guess what? It's coming up right now. Left that one out on purpose. So let's move on to the EMG. And from the start here, it's pretty straightforward, right? Deltoid, biceps, triceps. We do that all the time on our radiculopathy screen. But then, yeah, here we go. Trapezius, supra and infra, latissimus and pectoralis. Interesting choices there. And then, yep, serratus anterior. You were probably looking for that one. These are all normal except for that one. That is the only one that's abnormal. Reduced recruitment, about 25% of normal. Active motor units that are appearing, and decreased insertional activity. I didn't put it in here because it wasn't completely out, but it did appear decreased. So what is our diagnosis here? And yeah, you guessed it, it's long thoracic neuropathy. This is our medial scapular winging case. Now, if you wanted to see the waveforms here, that was really questionable. This first one here, you could argue that the ground was coming off, which it likely was. Once we got it back on, we got a much more stable baseline. Had to decrease the microvolts per division down to 500 to find it. But there is a clear break right there, so that is real, but it is tiny. It's like 0.1 to 0.3. Contrast that to medial antebrachial cutaneous, a nice clear waveform right there. We're at 20 sensory. We bring the divisions down a lot since it's a smaller sized response. And then compared to a more quote unquote standard motor, that's 5 millivolts per division, beautiful waveform there for spinal accessory, but really got a very poor response. We can actually say a lot about this case, and this is the nice thing about EMG. We can say, is it acute or chronic? This is a chronic case. It's pretty darn severe since there's such a minimal amplitude. And actually, we can talk about prognosis because decreased insertional activity indicates some component of atrophy. And we don't see nice large amplitude motor unit potentials, which we usually see when there's denervation-reinnervation changes when we get collateral sprouting. So that does not carry a very good prognosis, unfortunately. Now, some of my students have said, hey, wait, hang on. All I know is median and ulnar motor. You got to review this in a little more detail. How do you do all those? And we're going to go over them right now. They can be a little technically difficult to do and actually rather unpleasant if you've ever had it done on yourself. We're going to review it right now. Not so much fun. So how do we do long thoracic nerve? The ideal way, this is just a picture that I was able to find. They used a bar electrode. I don't like that at all. The better thing is use one of those disposable strip or ring electrodes that you can do wrapping around the finger and just place it longitudinally, just like this bar electrode, across the serratus anterior interdigitations, kind of starting right at nipple line and in line going down with the ASIS in this picture here, in approximately the anterior axillary line. E2 you place a little bit farther down in that same line, or you can just put it right on the lower sternum. You place the ground. I usually put it on the lat. Some people also put a ground on the sternum. And then you stimulate, yeah, exactly where they're showing, right in the armpit. This is not a fun thing to do. And you actually have to use a fair amount of pulse width here. You got to crank it up to 200 or even 250 and go up to about 50 or 60 milliamps, actually, despite the nerve being right under the skin. I mean, it is right there. But this is just the reality of long thoracic nerve stim. You got to crank it up. These are some reference values that are out there if you are not comfortable doing it or you don't happen to do the other side for comparison, although you usually like to. This is kind of the waveform that you get on the affected side, and the other side should be a nice, clear difference. We got a really bad waveform there in our case. Some people say, now, if I stimulate here, why can't we go proximally and stimulate at Erb's point? And yes, you can, but what's going to happen, right? Pause, think about it, figure out what the problem would be with this. All right, I hope you thought about it. Volume conduction, right? The lats or pecs, when you stimulate up at Erb's point, you're going to get everything else in the 5, 6, 7 area there, and you're going to get a messy waveform if you do it proximally, so it's usually not done. Another idea is, what about needle stim, right? Using that. We still like surface over needle because, well, you're risking pneumothorax, number one. It's certainly less uncomfortable for the patient, and you're not going to get as many problems. So we still do nerve conduction with surface electrodes. I would not use the bar. I would use the strip electrode, and you get some really nice waveforms. All right, the other one, right, the contralateral from medial, we've got lateral scapular wing. And this one is actually a lot easier to do. Once you've done one, then you're like, hey, wait, this is pretty easy. I could incorporate this, no problem. You go right at that posterior triangle, kind of at the midpoint, posterior border of the SCM, right in that spot there. And that's right where the nerve comes out and becomes superficial. Also, unfortunately, it's the spot where biopsies can nick it. And sometimes, well, actually, most of the time is usually when I've seen cases. It's often like a breast cancer patient that's getting staging and whatnot. They get a lymph node biopsy, and unfortunately, they come out with scapular winging. Same thing here. You got to crank up the pulse width to get a good response there. Some reference values that exist. Conduction velocity is a lot higher. It's similar to doing proximal nerves in the upper arm, like the median, radial, or ulnar, actually, where you get a much higher, quote unquote, normal conduction velocity or reference value. Some people also say, well, why don't we record the lower trap to make sure? Because if we're recording at the upper trap, maybe we're going to pick up levator scapulae underneath. And that is true. I usually end up just doing the upper trap. Now, some of you might say, hey, wait a minute, this could be Parsonage-Turner. And yeah, you would absolutely be right. In Parsonage-Turner, regarding the nerve conduction in EMG, it's primarily motor in terms of the manifestations. You are going to get low sensory in terms of amplitude. Motor is also going to be primarily low amplitude. It is patchy, and we're going to get into this representation here with Parsonage-Turner. You want to check median, you want to check ulnar, you also want to check the upper ones that, well, honestly, I was doing in this case: suprascapular, musculocutaneous, long thoracic. These are all upper trunk problems that are commonly affected in Parsonage-Turner. Again, you could stim at Erb's point, and you might get some degree of conduction block or low amplitude, but it's not usually a demyelinating issue. Parsonage-Turner, unfortunately, it's very axonal in nature. So let's talk more about Parsonage-Turner. Quick review here: 10% of people actually have a family history, which is kind of scary when that happens. 10% of people, it's some stressful event to the body. And we have had some of these. Living here in San Diego, a lot of people play pickleball, and they just, well, expose their body to something unaccustomed and particularly strenuous, and the body perceives it as stress, and it's a stressful event. Infection would be another stressful event. People often get, well, some kind of flu-like illness can happen. You can get it after a vaccine. I've even seen a couple cases where a patient goes to someone that does manipulation and then they get it after that. It's just some very strange stress to the shoulder girdle region, and then Parsonage-Turner develops. The classic story: fairly sudden onset and actually rather painful, nervy-like pain. I often talk about burning and aching, and then that goes away, but then sure enough, they start getting weakness in this weird patchy distribution. It's about a month in terms of the pain. The weakness slowly sets in and then takes over, and it's primarily a weakness issue. And it really sucks. It takes a long time, a year and a half, for them to finally start getting better. There are some very interesting histology changes. They can get fascicle enlargement. If anyone has ever heard of the hourglass kind of changes to the axon and the nerve, that can happen. And now we're starting to realize that there's some twisting that can go on to the nerves with adhesions and scar tissues, and you can start to observe that. If you're really good and have a very high quality ultrasound, which we don't have, but I've watched this at conferences, you can get this torquing, so to speak, of the nerve, and those cases actually might benefit from surgery. We didn't think Parsonage-Turner would often go to surgery, and it doesn't, but if you can identify that, patients do get better. So let's talk a little more about the EMG and Parsonage-Turner. Sensory is not as common as motor. It's usually going to be the MABC or lateral antebrachial cutaneous. You should do side to side if you're going to do it by the book and get a greater than 50% reduction. In terms of most common to least common, 72 down to 52. So I just bookended these. These are the most common muscles. Serratus anterior is right up there. Biceps, a heck of a lot of time I've found that. So I never miss doing musculocutaneous, which will be EMG to the biceps, and lateral antebrachial cutaneous, just to make sure. You can get some distal muscles, often AIN and PIN, so you want to check those muscles as well. If you're going to do ultrasound, you're going to see very similar findings. You just got to wait long enough, unfortunately. And that actually is kind of built in, because usually these patients roll into EMG clinic when it's been like a year of symptoms and they're not getting better, and then they finally go to the doctor and then they send them for an EMG. We have seen it in the era of post-COVID here after COVID vaccinations, absolutely. And some people say, oh, no, it's COVID issue. Well, it's actually the rates are exactly the same as flu vaccine. I've had a ton of cases over the years after getting a flu vaccine or shingles sometimes, and COVID is no different. What are some key points? We've been talking about this a little bit. Very patchy involvement. I often do musculocutaneous, long thoracic, suprascapular. I do axillary sometimes. I often do the physical exam first and see if there's some obvious weakness. Um, Sometimes these are actual mononeuropathies in a way that the patient primarily presents with one area of weakness, and that's all that really comes up on EMG. Oh, it's an AIN syndrome, but there's not really any forearm stress or twisting, or the person's a chef or something like that where they're grabbing and twisting at the forearm. But if you drill down on the history, you actually find out that they had some previous infection, for example, and it's a mononeuropathy, but the clinical picture fits Parsonage Turner. Those are often the PTS that flies under the radar. Now, the traditional teaching is, yeah, most people are going to recover. It might take a year and a half to finally get that recovery, and then it'll progress the next 2 to 3 years. Now we're finding out, yeah, that's not the case. About 2/3 of patients are going to have residual issues. I feel kind of jaded and biased because I get all the patients that don't get better after Parsonage Turner and they come through for EMG, but I believe that number. Even the severely affected, as in this case, even though it's not Parsonage Turner per se, can get recovery. If they had long thoracic nerve being affected, they can start to get some recovery. It might be only partial, but there is some degree of recovery, even in severe cases of Parsonage Turner. Some people say, well, why expose them to EMG? If MRI is so good, why don't we get an MRI of the plexus? And you can, but if you get this patchy involvement and it's mainly distal muscles or farther down the arm, you're not really going to see anything with the MRI. Now, I know if you've been through this, all my students kind of say, hey, come on, where's the ultrasound? You're a big ultrasound guy. How come this hasn't come up yet? And well, here it is. This is my, well, still lower quality ultrasound. I'm waiting for the new one. It's coming. This is serratus anterior and the muscle thickness, nice hypoechoic muscle on the unaffected side on the left. That's the border of the rib. That's another rib, and that is pleura. That's why the serratus anterior is very close. When you're doing needle, you want to make sure you're right on top of the rib and not in between, otherwise pneumothorax. Here's the end of latissimus, also dark and hypoechoic, meaning healthy water-filled muscle, and then the serratus anterior as well. Thickness here about 7, so that's a nice healthy amount of serratus anterior. When we flip to the the affected side, a lot more hyperechoic and a lot more atrophied. We're down to 3.9, so it's almost like a 50% change. Latissimus there might not be the best picture, but it is darker there, more hypoechoic relative to the hyperechoic serratus anterior. So you can get similar numbers, just like doing side-to-side nerve conduction. You can do side-to-side ultrasound. Much less discomfort to the patient. They can even sit up. I'm going to do a video on ultrasound in scapular winging. So watch out for that one. It's coming, where I can review all these different positions in terms of how to get these views here. Other ones to do: trapezius, rhomboid, erector spinae to check, and these are all nice and hypoechoic. So if we're worried about this patchy distribution, this all looks pretty normal. Here again, if you get right on the spine of the scapula, we got levator scap underneath the traps, and then supraspinatus. And if you go a little further laterally along the shoulder, you get more of the supraspinatus here. And these are all nice hypoechoic, healthy appearing, thick muscles. This now does not seem like Parsonage Turner. It really does seem isolated to just one muscle, which is serratus anterior. Finally, we'll pull in the clinicals. This is a 52-year-old female. I hurt her right shoulder after hernia surgery, apparently. She doesn't know. She just awoke and her shoulder was just killing her, and she just felt like, I can't use it. It just moves weird. She had this, well, vague kind of burning, aching heaviness in the shoulder, and she did feel stuff going down her arm, and that's where you say, aha, that's why you did the radial nerve. And if you go all the way back, yes, we did pull in the radial on that, but it actually got better. And this is very common when people have these kind of vague, sort of neurogenic, neuropathic. Some people describe these paresthesias, but it's usually this aching and burning symptoms in the shoulder, and then you can't use the rest of the arm because your shoulder doesn't move well in space, and then you complain of these distal symptoms. So we see this a lot with winging. People describe all these kind of funky, well, neurogenic sounding cases, but if you really kind of pin it down, they really shouldn't have a true sensory disturbance. They just complain and talk about it, which is why we added on more testing here, and we often look for things like Parsonage-Turner in this case. To finish up, sorry, this one took a little longer than usual, but I like to wrap it up, right? Our process improvement. What could I have done better? You might have picked up on a couple things that I didn't do or I should have done, or maybe you do something different. I'd love to know what you do. For me, well, probably didn't need to do the latissimus. There are still some surgeons that use the latissimus as a donor in really bad cases of winging. Really, that's kind of fallen by the wayside. Most people are doing the pec, split pec major. And I've come across a few cases of these. It's pretty fascinating. You take down the pec right there, you split it. So you take some of it there, leave some of it there, and then pull it through and then attach it to the inferior border of the scapula. And then they can still get some movement of the scapula when they go to forward elevate their arm. So it's a good idea to do it just to be comprehensive, to show, maybe more in a Parsonage-Turner or another case, that the pecs are fine. They're a good donor source. Now, I do Parsonage-Turner in one way. I just tend to see a lot of biceps, lateral brachiocutaneous, serratus anterior, and then suprascapular. But maybe you do a different screening. I would love to know. Please leave it in the comments. I would like to improve myself. If we're going to do a formal winging, well, maybe we should have added the sternocleidomastoid. I didn't do it. It's an uncomfortable one. It can also be a little bit scary when you're doing and you're not used to doing those. I did the trapezius. I only did the upper. You could actually say, well, why don't you do the lower? And the reason why is, can anyone think of this? If you have a really bad case of lateral scapular winging, if you've ever seen it where the trap just completely atrophies, what you're left with is a very hypertrophic levator scapulae. So if you're in the upper, well, if you think you're in the upper trap, you might actually be in the levator scap. And then, well, you're going to get a false negative or a positive, in this case, a false negative. More and more, though, as I'm going to conferences, I'm finding that a lot of the academic people and faculty around are starting to just skip doing nerve conduction and EMG altogether and just go straight to ultrasound, which is pretty fascinating. Should I have done long thoracic nerve conduction in the opposite side for a comparison side to side? Well, I could have, yeah, and if on paper we're looking at this case, I probably should have, but it's really unpleasant to do it in the opposite side, so I actually don't often do it. Yes, if you're going to be strict and judge this case, probably should have done the opposite side to be comprehensive. That would be a better assessment of Parsonage-Turner, neuralgic amyotrophy. But in this case, I don't think it really added. The diagnosis was pretty darn clear. It was just one muscle involved on nerve conduction, on EMG, and on ultrasound. I think it was a slam dunk. But think about this. Let's say it was Parsonage-Turner. Would it really change? This patient presented, I think it was like 6 or 8 months after the initial problem. We're going to send them to therapy, right? They're going to do their rehab. We're not suddenly going to flood them with steroids or IV treatments or whatnot if this is a case of acute Parsonage-Turner, since we're already past that window. Are we suddenly going to send them for surgery? Probably not. Are there any injections or braces that we would do differently for Parsonage-Turner or scapular winging? Probably not. And sometimes, as we were talking about before, Parsonage-Turner can occasionally present as just a weird mononeuropathy, like an AIN that just came out of nowhere, and it's actually Parsonage-Turner. So watch out for that. Now, I'm going to leave you with this. I do tend to get a little philosophical sometimes in my lectures. Going to go through some teaching points. Going to leave you with one teaching point that, quote unquote, makes you think. The initial question here, most common radiculopathy by level. This is a pretty standard question. Most people know that the most common is what? Yes, C7. Then we go to C6 and then to C8 and the last, C5 and then the last one, C8. Yes, these numbers do add up greater than 100 because some people have more than one radiculopathy, but these are the numbers that are out there. But the interesting thing is C7 radiculopathy often has subclinical scapular winging, or sometimes it's clinical, but you're just not looking for it and it flies under the radar. They're having all this burning pain shooting down their arm. You're just focusing on the radic and you don't realize they're having winging with that radiculopathy, which is kind of neat. Which brings up this great quote that someone told me years ago in my career, and it's just so inspiring, right? You only find what you're looking for. You only look for what you know. So you got to know what to look for. And this is so apropos in the world of EMG. You have to have your mind open to very different possibilities. Otherwise, everything is just going to be carpal tunnel or radiculopathy. And it's not, right? It's out there looking at you. You just got to know what you're looking for, which then takes me even more philosophical. We're starting to drift a little out of the medical world here, but there are some famous people out there who have inspired me, certainly. And they all have very similar sayings that kind of overlap that quote from the previous slide here, some of them being Emerson, Thomas Edison, and Van Gogh, right? We only see what we know. So keep your mind open. This is very relevant in EMG. Watch out for multiple diagnoses that might be there. When I'm at the top of the mountain, like I'm trying to be right now, I often think about these philosophical things. So wanted to leave you that. Have a good one. If you have any comments, please, I would love to learn from you. Let me know.